Thanks for the invitation to talk, Carl. So I was going to give you an overview of some of the lung MRI studies we've been doing in the last 2 years since COVID kind of dropped itself upon us. And really the only highlight of COVID for me has been the fact that our lung MRI methodology has kind of really come into focus, how it might be useful to understand some of the mechanisms going on in COVID. So it's given us a chance to do some work, which during lockdown was a real bonus, but B, it also, I think, has brought into focus what we can measure with some of our methodology, specifically around gas exchange. So, this slide really, I suppose, summarises where I see functional and structural imaging in modern kind of respiratory medicine. We've got this regional sensitivity. Lung function tests are notoriously insensitive and regionally non-specific. With functional and structural imaging together, I think we can kind of get a better understanding of lung physiology mechanisms and also use the imaging to guide better kind of treatments as well. So that slide really sets the scene, and I'll possibly talk about how we see it being used in COVID later on. First off, start off with the methodologies though. So basic proton MRI, where we're imaging essentially water molecules and other organic molecules in the body, imaging the protons of them. It is coming along. So here we've got this ultra short echo time UTE MRI side by side with CT, and the image quality there, certainly in diseases like cystic fibrosis and interstitial lung diseases where we get disease of the parenchyma, it's coming on leaps and bounds. So we can image quiescently in 3 dimensions during free breathing with these sequences. That's a patient with cystic fibrosis. And the same kind of pathophysiology that we see on CT is evident, albeit at slightly lower spatial resolution. So proton structural MRI is moving along leaps and bounds, and certainly in indications where you want to avoid radiation dose, such as pediatrics, or indeed in follow-up, so perhaps in follow-up of structural changes in the lungs post-COVID, for instance, there's a potential role for modern proton MR structural imaging. End of the day though, neither CT or proton MR can actually resolve the small airways where the kind of physiological work face of the lungs. So we need to look at other ways of measuring and quantifying lung physiology beyond CT, I think. The other thing we can do with proton MR is inject T1 shortening gadolinium contrast agents into the arm, and here we see the bolus passage of the agent through the lungs. So you see in the pulmonary vasculature there the time course of signal enhancement as a bolus of T1 relaxing gadolinium agent passes through the lungs. And from the passage of that agent, using tracer kinetic theory, we can compute maps of regional blood volume, regional blood flow, and mean transit time, so the time it takes for the contrast agent to clear the lungs. And all of those tell us something quantitatively about lung perfusion that we can't actually achieve with conventional methods. So the mean transit time, if we've got pulmonary vascular resistance and weak cardiac output, as in diseases such as pulmonary hypertension and indeed in interstitial lung disease, where the heart's pushing blood against a resistance due to, for instance, kind of interstitial thickening and kind of vascular remodeling, it takes longer for the contrast agent to clear the lungs. So quantitative information that you can't really access by other means with MR. So that's proton MRI. And then the other side of what we do is xenon MRI. So this is kind of less kind of accessible, but we're working on improving the accessibility of it. Here we're imaging inhaled gases. So xenon's a noble gas, atomic weight 54, molecular weight 129. It's got a nuclear spin half, the 129 isotope. So that's kind of picture of the xenon atom there. Name derived from the Greek for strange, and it does have some strange and quite interesting properties from the point of view of MRI and magnetic resonance. In order to get a signal from a gas like this, we have to polarize it. So we don't rely on the scanner itself to magnetize the gas. The magnetization of the gas comes from a process called laser optical pumping, spin exchange optical pumping, and that's where the laser device comes in. So in order to do this, you need a initial piece of kit as well as the MR scanner. And with small doses of inhaled gas from a bag like this, typically half a litre, we can get information like this about lung ventilation. So clearly kind of new and interesting regional information on lung function there with these inhaled gases. Because the magnetisation is largely coming from the laser rather than the scanner, we can image at different field strengths. So here's just some comparison of lung ventilation images with xenon at the two kind of clinical field strengths of 1.5 and 3T. Shows you that it's feasible at both field strengths. We also need additional coils just from a practical perspective. So we can do this on standard MRI scanners, but we need additional coils or radio frequency antennas to pick up the signals because the xenon resonates down at a lower frequency, about a quarter that of protons. So at 1.5 Tesla, it resonates down at 17 megahertz. So we need additional body coils to pick up the signal from xenon in the lungs. And there's different kind of designs for that, but it's an add-on to the system that needs to be considered if you're interested in this. So alongside the polarizer, we need RF coils as well. What can we measure with xenon? So this cartoon kind of highlights, I suppose, the different aspects of pathophysiology and physiology we can measure down at the airway capillary interface. So here we've got an alveolus and a capillary. So the easiest thing we can do is, like in the images I just showed you, we can just measure a map of spin density. We're mapping basically the distribution of air in the lungs, the inhaled xenon, with lung ventilation. The other thing, it's an inert gas, it's a noble gas, it's diffusive. It bounces around by Brownian diffusion in the airways, and we can sensitize MRI to diffusion. We apply diffusion gradients and we measure the Brownian diffusion of the gas in a kind of Brownian sense within the airways. And from that, we can, by measuring the apparent diffusion coefficient, we can get a feel for the length scales of the airway microstructure. So we can measure length scales by measuring the Brownian diffusion with MRI. So that's interesting where we've got alveolar disruption, for instance, in COPD, emphysema, but also in interstitial lung disease where the alveoli get remodeled and pulled apart by traction. We can actually measure microstructural change there in the airways. And we've got models actually we superpose on those measurements to give us even more information. I'll talk about those in a minute. So that's kind of Brownian diffusion. And then there's diffusion in the kind of membrane transfer sense. So measuring diffusion across the alveolar capillary membrane, and where we've got interstitial changes, where there's endothelial disruption, thickening of the interstitial alveolar capillary barrier, we can measure this kind of dissolved diffusive exchange. So that's kind of gas transfer in the classical physiology sense. We can measure xenon in the gas phase. We can also measure it in the dissolved in the tissue or the membrane, and we also measure it in the red blood cells as well. So it's got a discrete resonant frequency in each of these compartments: alveolar gas compartment, tissue compartment, and red blood cell compartment. It actually gets taken up by the red blood cells and absorbed by the red blood cells. And it's got a discrete chemical shift that depends on the red blood cells' oxygenation as well. So some really quite interesting physiological properties there. And the ability to separate xenon in these three compartments makes it a really powerful tool for studying gas exchange and gas transfer down at the alveolar capillary membrane. So starting with the simplest thing, I suppose, ventilation. Obvious applications there in obstructive airways disease, where we see distribution of gas and visual lung physiology, essentially. We can visualize the ventilated air spaces. There's some example images in different pathologies. We can quantify this by various means. The simplest thing to do is just binarize the images and say black space is non-ventilated and grey or white space is partially ventilated, and you can segment. And this kind of crude ventilation defect percentage measurement is actually quite sensitive. It picks up early obstructive lung disease related to smoking, cystic fibrosis. So the ventilation defect percentage, albeit a quite crude measure from quite rich 3D information, is very sensitive at picking up early lung disease before spirometry. And then we can start to be a bit more elaborate. We can start to look at the texture of the images and the ventilation heterogeneity by looking at things like coefficient of variation. Moving on now to the microstructural information. these are images comparing maps of the, basically what we're doing here is we're measuring multiple diffusion weightings with different gradient strengths, and from that we compute using stretch exponential models, a kind of model of the distribution of the airway sizes and also the mean size of the airways. So this is kind of stretched exponential modelling of the diffusion signal, and what we're computing is analogous to histology, where we've got a mean linear intercept. So a histologist would count the mean distance between alveolar walls on a grid like this. What we've got here with xenon and indeed helium MRI, helium was the gas we used in days gone by, xenon's the gas we're using now. We've shown that we've got this gradation and ability to kind of measure alveolar disease progression as kind of alveolar sizes increase with disease progression. So in smokers, we see elevated mean linear intercepts, and then in emphysema patients, we see elevated mean linear intercept. So this is one of the tools that we've applied to COVID alongside ventilation. And then perhaps most interesting, as I said previously, is the fact we can measure the gas exchange. So here we've got the xenon nucleus, and it's got a large electron cloud. And that electron cloud, depending on the environment the xenon dissolves in, shields the nuclear spin, and we get a shift in the resonant frequency depending on the compartment that the xenon's dissolved in. So it's not a particularly soluble gas, but it does dissolve in tissues and blood. So here we've got a cartoon of a healthy alveolus, so large, well-ventilated alveolar airspace, thin tissue membrane, and then a well-perfused red blood cell supply. And what we see in a dissolved xenon spectrum is a large gas peak, and tissue peak or membrane peak, and a red blood cell peak, which are equivalent in size. If we now look at a model of, say, idiopathic pulmonary fibrosis, interstitial lung disease, we see possibly a restricted airspaces, so reduced ventilator volume perhaps, but definitely a increased membrane thickness due to interstitial thickening, pulmonary fibrosis, or indeed possibly endothelial pneumonia, so increased water content in the membrane, and then possibly reduced red blood cell signal due to impaired perfusion. And we see a big imbalance there with an elevated tissue peak from the membrane and a reduced red blood cell peak. So we've shown that method to be really sensitive in previous studies in IPF, where we can measure disease progression. So that's an obvious candidate for kind of trying to understand the pathophysiology of COVID. So using these four methods essentially, so we've got the structural imaging with proton MRI, then the contrast enhanced perfusion imaging from gadolinium enhanced proton MRI, then we've got xenon ventilation imaging, xenon microstructural imaging with the diffusion weighting, and then dissolved phase xenon imaging using this spectroscopic imaging approach to really try and understand the kind of pathophysiology of what's going on in COVID patients. So various studies took off during the last 2.5 years, really. The first one we got off the ground about 2 years ago, plus just over 2 years ago, was what we call the MERCO study, where we set out to follow up patients who were hospitalised and try to image them as soon after they'd been discharged from hospital, and then follow them up with time. So that's a longitudinal study, quite a detailed focused study. Then we've got the UK ILD study. So that's linked into a bigger collaborative project led by Gisley Jenkins at Imperial, where you've got kind of phenotyping, blood measurement, all sorts of different measurements taking place in patients who have been referred with what is thought to be post-COVID interstitial lung disease. So that's the UK ILD study. And there we had the great opportunity to set up a kind of multi-sensor xenon imaging study on the back of that, called the Xmas study, Christmas study. So there we've got Oxford and Nottingham as well, standardised protocols on 3 scanners in the 3 places, and Sheffield are kind of coordinating that. And then coming up, we've got the Explain study. So that's just started recruitment. That's been taken a long time to get off the ground. but pilot data from that study has already been published. And that's a study that we've done in collaboration with Fergus Gleeson at Oxford, where we're looking at post-COVID patients. So patients who have seemed to have got quite normal CT, no structural abnormality, but are complaining of ongoing breathlessness post-COVID infection. So there we're looking at long COVID patients with breathlessness essentially. And then finally, I'll touch on the Seymour study, which is a multi-organ proton MRI study conducted at 3T across multiple sites in the UK. So there we've got quite a basic lung protocol that we bolted onto that, but there, that study is more looking at different organ effects, so abnormalities of the brain, kidney, liver, and lungs and heart. So they're the 4 studies I'll touch upon, but the Merco study is the one where I'll kind of focus upon, because I think we've got the most kind of detailed mechanistic data there from that study. So that's a kind of schematic of the various studies and how we went about recruiting to them in Sheffield. So enrolled them in Merco. If there was any evidence of structural interstitial lung disease, they got moved over to the COVID ILD study, and then the Seymour multi-organ studies proceeding in parallel. So in Merco, we're looking at scanning patients as soon after release of hospital as possible in the acute phase, and then follow up at 6 weeks, 12 months, 6 months and a year. And then in the UK ILD study, I'll talk about that later on. So findings of Merco so far. So again, longitudinal study with following up patients post-hospitalised with proton and xenon lung MRI. This has taken place solely in Sheffield, and recruitment to that study has been challenging, but thankfully due to cooperation of patients and great effort from our team in getting the patients in, we've managed to get a very interesting data set. So that slide summarises the kind of recruitment, the kind of demographics. So we're looking at patients hospitalised, typically about 60 years, 57 years average age. BMI is there, 3 out of 9 of them were female. So quite a small study, but a detailed study. And then if there's any signs of ILD, they were excluded from this analysis. So any evidence of architectural distortion on CT or proton MRI, and they were referred to the UK ILD study instead. So these are methodology. So I mentioned the dissolve phase imaging. So here we're mapping the different compartments of the lung, the membrane, the tissue, the red blood cell signal, and then we express them as ratios, the ratio of red blood cell to membrane or tissue. They're interchangeable, tissue and membrane. So what we see here in healthy normals, that ratio is high, so you've got good gas transfer, and the xenon dissolved in the red blood cell compartment is high. In patients with IPF, we see reduced RBC to membrane ratio. Equally in COPD we do. So in IPF, there you've got an increased membrane signal due to interstitial processes. In COPD, typically we've got loss of gas exchange surface and reduced capillary perfusion, causing those reductions in ratios, but giving us some mechanistic understanding into regional gas transfer with these maps of xenon ratios. Right, so moving on to the results. So here's a typical 3D ventilation data set. Here's a typical UTE image from one of our post-COVID patients. So we see some residual ground glass pneumonia there in the acute phase. So the proton MRI is picking up some of the gross structural abnormality post-infection. This is an overview of the images we've scanned. So visit 1, 6 weeks, then visit 2, 12 weeks, visit 3, 25 weeks, visit 4, 50 weeks. And we see some evidence of kind of resolution of some of the post-infection pneumonia residual ground glass changes with time there with the UTE imaging. So potential for UTE to be used in lieu of CT, I think, for structural follow-up. So that's a free breathing proton MR scan. So they're, for the 9 patients we've scanned, they're the data we've got for structural follow-up. Interestingly, with the ventilation imaging, most of these patients showed very mild ventilation heterogeneity. So ventilation defect percentage of 2 or 3 is kind of what you'd expect from someone who's a hay fever sufferer in the summer, or a healthy normal in the winter who's possibly had a cold or a cough. So this is kind of confirming to us that this is not a small airways or large airways disease, and that's kind of consistent with what we're seeing in the literature. Largely, these patients' lungs were quite well ventilated. There's definitely some heterogeneity in ventilation, but usually that kind of corresponds to where there's some residual structural abnormality, residual ground glass infection, these kind of things in this group of patients. So possibly don't read too much into these data, other than that most patients' ventilation defect percentage seems to kind of go down with time. We've got a couple of outliers who've gone up again there, but yeah, ventilation defect percentage of 3 or 4 is not really indicative of severe airways disease from our studies in obstructive airways diseases. But they're the ventilation imaging data from the patients with time. Moving on to the diffusion weighted imaging. So this is looking at the microstructural data and how the mean linear intercept changes with time. So here we've got age and sex matched healthy normal ranges for both the mean linear intercept, which is the estimate of mean airway dimension in micrometers, and then the actual apparent diffusion coefficient of the gas. So they're the two quantitative measures we can use to quantify microstructural, the diffusion within the airways. And we see no significant change with time in any of the patients. We see a trend of slightly reduced mean ADC and mean linear intercept. And we think that may in part be due to the fact that the patients struggle to inflate their lungs, possibly to the same level as healthy volunteers. So possibly partially fully inflated airway size. Another hypothesis is there's some residual kind of pneumonia in the interstitium, and that's kind of creating a micro kind of slight reduction in the alveolar space, just due to residual kind of water in the lungs. But either way, no real significant change there, no signal to change, and no significant difference to healthy age-matched normals. So far we're seeing fairly normal ventilation and fairly normal airway microstructure, consistent with this not being a kind of small airways disease pathology. Moving on now to the dissolved phase xenon, the gas transfer imaging, and this is where we start to see some really interesting changes. So red blood cell to membrane ratio of about 0.4 is what we'd consider for healthy age-matched normals with this methodology. All of our patients that we scanned at visit 1 had significantly depleted red blood cell to membrane xenon gas transfer ratio. And then as we follow up with time, thankfully, most of those patients seem to be on a trajectory where things are getting better, but they're not yet getting back to the kind of levels that you see in age-matched healthy normals. So there we're seeing an improvement in red blood cell to membrane xenon ratio, as hopefully the capillary perfusion starts to improve again. But yeah, not getting back to the levels that we see typically in normative data. But the ability to monitor change there and improvement, I think, is significant. Certainly between the post-acute and follow-up data, you can see the significance levels there at the visit 1, visit 2, and visit 1, visit 3. So that's kind of the xenon gas transfer measurement. And now we're looking at the dynamic contrast enhanced perfusion MRI. So this is the gadolinium injected in the arm, and then we measure, here we're measuring the pulmonary blood volume in these patients with, in a cross-section of the patients. Now, not all of the patients tolerated the gadolinium enhanced imaging at every visit, so we've got a few missing data sets there. But interestingly, what we see in most of these patients is an improvement in pulmonary blood volume with time. And that's kind of consistent with what we see in the xenon red blood cell to membrane ratios. So as microvascular capillary perfusion improves with time, we see that in the quantitative perfusion imaging. What's interesting from these perfusion maps is there's no real clear-cut kind of classical wedge-shaped perfusion defects that you would perhaps see in thromboembolic disease, chronic thromboembolic disease. So what we're looking at here is not a large blood clot in one of the main blood vessels. It's a more diffuse capillary perfusion abnormality consistent with a kind of shunting of the arterioles and venules. So the capillaries are just kind of, the red blood cells are just not getting into the capillaries is the hypothesis here, because you don't see any focal large scale heterogeneity in the perfusion imaging. And equally, if we look back at the xenon red blood cell membrane maps, they're fairly uniform as well. So we're talking about a diffuse abnormality here, largely in these patients scanned post-COVID. So bringing those together, in the few patients where we've managed to get DCE perfusion imaging and xenon red blood cell membrane imaging together, you can see that the correlation there on a point-wise basis is pretty obvious. As xenon RBC membrane goes up, the pulmonary blood volume from contrast-enhanced perfusion imaging is going up. So we see a correlation there on kind of pairwise between the different sets of measurements. This cartoon that Laura Saunders put this together, it's kind of nice diagram summarising what we think is going on. Essentially, we think that we've got reduced red blood cell uptake of the xenon due to the fact that there's less red blood cells getting into the capillaries. We don't think we've got membrane abnormality or much of it. We don't think we've got any ventilation abnormality or any change in the airway microstructure. What we've got is a reduction in the capillary perfusion down at on the other side of the membrane. Red blood cells are just not getting through and picking up oxygen as well as they are in healthy lungs. And that kind of is consistent with what people are complaining about in terms of their breathlessness. So kind of shunting of the capillaries really, so that blood is just not getting into the capillaries. And that's reflected by the two sets of measurements. So that kind of summarises the findings of the MERCO study so far. It's an ongoing study, patients are coming back, and we'll carry on following these patients up with time. And hopefully we'll start to see a recovery of these measurements, the RBC to membrane, with time, and hopefully see that correlate with an improvement in patients' kind of underlying apnea and symptoms of breathlessness. So that work we're trying to get published at the moment. Moving on now to the long COVID lung fibrosis study. Working with several sites now to try and recruit into this study alongside Oxford and Nottingham. So we've got Manchester enrolled as well. That slide kind of summarises the recruitment pathway for that. So it's quite complicated. The patients have to have a query of interstitial lung disease as diagnosed by architectural distortion in their CT in order to be enrolled in this study. And what we're finding is there's not that many patients with clear-cut interstitial lung disease related to post-COVID infection. Most of the ones we're seeing tend to be the patients who've been on ventilators and have got kind of structural lung disease possibly associated with being on ventilation. So this is a summary of the patients we've recruited so far. Again, most of them hospitalised. Here's some examples of their structural imaging, and you can see more significant structural abnormality on these patient scans. The UTE and the CT together kind of marrying up quite nicely. The nice things about the UTE images is they've got slightly different contrast to CT, so they're weighted a bit more by water content. So we have got the ability to kind of delineate possibly better between fibrosed lung and ground glass changes, for instance, with the UTE images. So the contrast is not exactly the same, but the kind of crude pathology is visible there in the structural imaging. There's some examples of patients with quite severe looking architectural distortion in the lungs, post-COVID infection, and just some examples of the different modalities we're scanning with. Again, the xenon ventilation MRI In these patients, though, we do see elevated pneumonia intercept and the diffusion weighted parameters. They are changing where you've got architectural disruption and structural change in the lungs. We see elevated diffusivity, and again, quite impaired xenon red blood cell membrane signal. And interestingly, in these patients, also some more heterogeneity in their perfusion parameters because their lungs are more generally more structurally kind of heterogeneous. So there's some example maps. These slides are quite complicated to read, but they kind of summarize where the different measurements that we make are abnormal. So green is in normal range, red is clearly abnormal. And we're seeing in these patients, we see some abnormality in the microstructural information from the LMD and the ADC, but again, quite severely depleted red blood cell membrane gas transfer measurements in these patients, as we saw in the kind of follow-up study. And again, the ventilation volumes not massively. So here the ventilation volume VV percent is the inverse of the ventilation defect percentage. So it's 1 minus the ventilation defect percentage. But yeah, in those patients, again, not a massive amount of ventilation heterogeneity either. Usually where we see it is where it corresponds to structural abnormality. There's kind of the same patient's lung function. So you see in the carbon monoxide gas transfer abnormality there where we see RBC, xenon RBC membrane abnormality as well. So rightfully so, you see a kind of correspondence bit there between a lung function test and a regional gas transfer test, and then the other lung function data. So that's the UKLD study. Now I'll just touch briefly on the preliminary work that led to the EXPLAIN study. So this is early work we got off the ground with Oxford early in the pandemic, where we installed some of the methods that I've shown you on Oxford scanners. So working with Fergus Gleeson and James Grist down there, we installed the dissolved xenon red blood cell membrane kind of sequences that I showed you. So we've got standardized methodology now across the 2 platforms. And in Oxford, they recruited some post-COVID patients who had normal or near normal looking CT. And interestingly, in those patients, this was published in Radiology quite recently, and it was all over the BBC last year. We see this depleted red blood cell signal from the xenon, even though the CT structural imaging looks normal. And then follow-up of that study, again in Radiology, we've looked at differences between healthy controls and the post-hospitalised and non-hospitalised post-COVID breathlessness patients. So there you've got the red blood cell membrane, red blood cell tissue ratio for xenon in groups of patients who were hospitalised and complaining of post-COVID breathlessness, and non-hospitalised groups. Both show significant differences between when compared to age-matched healthy normals. We don't see a difference between the 2 groups at the moment, but there's a trend there. And hopefully we'll get a lot more data there through the EXPLAIN study. So the EXPLAIN study will be opening up recruitment to Manchester and Cardiff, hopefully. So patients from Manchester will be coming to Sheffield, and patients from Cardiff to Oxford. Big study there funded by the NHR. So that's the EXPLAIN study. And then finishing, last but not least, with the Seymour study. So this is the multi-organ scanning protocol that was kind of coordinated by Betty Rahman, a cardiologist in Oxford. So this was all done on 3 Tesla scanners, and there we've got quite a comprehensive protocol to look at post-COVID abnormality in all sorts of organs, so brain, heart, kidneys, liver, lungs, and Sheffield are the core imaging lab there for the lung imaging. So there we've done what we call fast spin echo haste imaging, looking at structural abnormality, so just looking at signal changes in the lungs, analogous to how we do with the UTE scanning. So there where you've got severe lung disease, we see brighter signal intensity from those patients. And as you'd expect in a cross section of patients who've kind of had these patients were aligned to the FOSP post-hospitalised cohort that many of you will be aware of. But yeah, in that cross section of patients scanned so far and analysed, we see increased signal from the lung parenchyma, representative of post-COVID structural abnormality in the lungs. And then we're doing lung perfusion imaging in these patients as well, and we're seeing trends there of increased mean transit times in these patients' lungs as well with the DCE. But it's early days on the analysis of that, but very large study, hundreds of patients. We'll hopefully see some interesting trends from that emerge. So there you see the mean transit time analysis from the early analysis of 200 patients, slightly elevated mean transit times when compared to healthy normals. So in summary, I hope the talk's kind of summed up where structural and functional imaging might sit in understanding respiratory diseases, and COVID is a very interesting model of that, really. This is a unique kind of trying to understand what's going on at the gas exchange membrane and where what the mechanism is of kind of ongoing breathlessness. I think what we've shown here is we've got some regional insights into that from measurements that complement each other. So direct measurements of capillary perfusion versus direct measurements of gas exchange across the membrane. And yeah, hope that this can be useful in trying to understand and model some of these aspects of kind of lung disease, different lung diseases going forward. Again, sharp tools. We come from Sheffield, and these are all made in Sheffield. Just like to thank all the members of the team and our collaborators. Okay, thanks, Carl. That's it.